Our fifth panel of the day is actually the most extraordinary one, and one that I've had the personal pleasure of being involved in. Dr. Darmstadt, Gary Darmstadt, who many of you know, will present our ongoing work, the ongoing work of his group looking at social gender norms and their impact on adolescent health. For those of you who don't know Gary, who in most crowds would need no introduction, we managed to steal or otherwise recruit Gary from the Gates Foundation a couple of years ago, where he had led a very large programs in maternal and child health and related things. He's trained in dermatology and in pediatric infectious disease, but in fact has made most of his reputation studying a wide range of health problems in the global environment, mostly related to maldistribution of good things. Gary arrived here a couple of years ago. He's Associate Dean for Maternal and Child Health, and he's been leading this extraordinary project, which he will describe.
Mark, thank you very much. It's really a great pleasure and honor to be here. I appreciate the opportunity to talk about this work that really represents the work of many people here in this room, and this is work that we really have to do together. It's a very data-intensive exercise, but it's really bringing broad principles from public health together around that data to try to gain new insights, which I'll describe. So this has really been a fantastic partnership, and I'm just really delighted and privileged to be part of it. What I want to talk with you about is the way in which gender norms impact health. This is a subject that I got into gradually over years, as Mark was alluding to. I have done work over the course of my entire career in newborn health, in child health, in maternal health, in women's health, and always looking at disparities and the reasons behind those disparities. And increasingly, as I went through my career, I felt that rather than be focusing on introducing interventions and often not knowing exactly why they didn't take off, that I needed to take a step back and to try to look underneath and to try to understand cultural norms and to try to understand gender norms. I increasingly became convinced that a big barrier that we all were facing as we were developing innovations, but then trying to introduce them into low resource settings to have impact there, were norms that often we didn't quite understand or we hadn't sufficiently taken into account along the way in order to realize the impact of what it was that we were trying to create. As I was at the Gates Foundation and spent as much time as I could in the field, and as I reviewed projects, I increasingly encountered ones like this that gave me this kind of insight and kind of awakening around these issues. This was a project I had the opportunity to review when I was the family health director, and I was looking at nutrition and the links of nutrition to agriculture. And here is a project that had a fantastic conceptual framework. The framework was that we would, and the Gates Foundation was funding this work, that we would fund the technology development and innovations around technology to enable women to grow soybean, to benefit economically from the sale of those soybeans, and that their children would benefit nutritionally and educationally from the value of the food and the money that was made from the sale of that food. It sounded fantastic. We launched the program, yields started going up, women were getting involved, and everything looked really great. And then a midterm evaluation came along and revealed that the project was starting to fall off. Women were starting to opt out. And we had to take another look at exactly what was going on. We looked at the nutritional outcomes, and there was no impact. No impact on any indicator that we could find. There was economic growth in the community, but that economic growth was not benefiting women and not benefiting children. So what happened? What we came to find out is there were a whole host of norms underlying the assumptions that we had made that turned out to not really quite play out in the manner that we had hypothesized. It turned out that men were involved in the sale of the crop, not so much in the production of the crop. Women were charged with producing the crop, but they were already working from sunup to sundown. They had what we like to call time poverty. They had absolutely no spare time on their hands, but yet they were the ones who were tasked with growing this new crop. And in order to do so, they recruited their children. It was about the only means that they had. They actually didn't have the means to recruit others in the community, and often it fell to their children to help them. And so, in fact, in particular, girls were being held out of school to help the mothers grow the crop. When the crop was produced, the men liked the fact that it returned that it returned money. They were the ones in charge of selling the crop, and they were the ones who then kept the money and decided how the money was going to be used. And it didn't get used to benefit the children's education, nor did that crop come back into the community to improve the nutritional value. So there are a whole host of normative behaviors around gender and the roles of women and the roles of girls that subverted the impact of this intervention. So we had to go back to the drawing board and think about, how do you more equitably make decisions? How do you more equitably distribute resources? How do you address these norms in order to achieve the impact that you were aiming for? So this is one of the projects that really woke me up to the importance of these issues. Gender norms essentially are the sometimes spoken but often unspoken rules that people are aware of and that they abide by, and that they imbibe in what it means to be a man or a woman or a boy or a girl. How do you think? What are you capable of? What can you dream about? What are you able to do? And there are many influences upon these norms that come from your family, come from the larger society, your educational place, your workplace, and these all influence the attitudes, the behaviors, and ultimately the health that we have. And these norms begin to shape us even before we're born, frankly, but certainly from the moment that we're born, they begin to shape us. Lest we think that these are just forces at play out there somewhere in a place like Malawi, how many of you have seen these word clouds before? Anyone? Quite a few of you. So you're aware of the fact that these forces are at play all around us. This is a word cloud taken from advertisements on TV for toys, in this case being sold to girls, and these are the words that came out in the commercials for these toys aimed at girls. And here are the ones for boys. Markedly different. Socializing boys and girls, and their parents for that matter, in very, very different ways. We can imagine that these kinds of gender biases have all kinds of impacts that ultimately end up impacting our health. In many of the places where I spend my time working, we see son preference at birth. This can have multiple spill-offs. There may be unequal allocation of health care, differentials in care seeking for boys compared to girls, or access to education for boys and girls. Women's work, as a result, may be made relatively invisible. They're not seen as the economic earners in the family. Also, as a consequence, men can often be excluded from, as we saw in the Malawi example, from the activities of childbearing, and may often be completely unaware of the issues there. And without them becoming aware, they may be making all kinds of decisions that do not result in more equal allocation of resources. And in fact, as Mark's work has even illustrated, it can shorten men's life expectancy for a variety of reasons. It was because of these kinds of factors that I decided to propose to the Lancet that we put together a series of articles, a Lancet series on gender equality, that was fundamentally formulated around the idea that norms affect all of us, and none of us are able to live up to our full human potential when these norms are impacting us. and that we need to understand them better. We need to understand how they're formed, how they're shaped, and how we can work within them and shape them to become more equitable, and that through these processes we can all improve the health of all of us. So the efforts of this Lancet series focus on efforts to transform gender norms, to address inequalities, and to understand how that is related to health and what those pathways are and how we can intervene. Our overarching objectives are to better understand these norms, understand how they influence health, be very rigorous in our evidence around them, and to get new partnerships, new conversations going to address these. And I think that's part of the spirit in which PHS is working in a multidisciplinary way to try to address these issues. There are 5 papers, which I won't go into detail here. Suffice it to say that our second paper is focused on the use of existing data and what kinds of insights can we gain from the analysis of that existing data that would help us to understand where norms are at play and where they're impacting health. Within this exercise, in looking at existing data, we're trying to trace out pathways between where we presume norms are acting, their influences on gender equality, and their influences on health. We're also more broadly looking in the literature at policy experiments, at research trials, and at program evaluations for ways in which norms have been attempted to be shaped, whether that's worked or not, and what kind of impact that has had on health. And in the process to understand where are there data gaps, where can we do better in collecting data, in using data, in being accountable for data. So when we think about a norm, one of our first challenges is how do we begin to look at data in a way that leads us to understand where a norm is existing and where it's playing a role. In thinking about a person and their view on what do others expect of me in terms of my behavior and how does that influence my behavior, we need to understand who is it that is influencing that person. What is what we call their reference group? Now, the reference group may be highly variable in its influence. As we saw in the slide on gender norms, there are forces all the way from the individual level out to the societal level, at the level of laws, that influence norms within a community, and how do we understand where those influences are coming from on a particular individual on whom we may have data. So here's an example of a girl who wants to go to school. The attitude of her family may be, well, girls should really stay at home. They should be the ones who are helping mom till the soil and grow the soybeans. But then there may be laws that are at play that say, actually, this girl has a right to go to school and she must go to school. How do these forces interact with each other? And how do we understand that by looking at data that's available? So we've approached this challenge by trying to pull together partnerships, and partnerships particularly around data that provide us opportunities to gain insights into these really challenging issues. Valerie may be able to talk a little bit about the process of acquiring the data. We started out with a very broad view in trying to pull together all the various kinds of data sets that related to health, where we thought we may be able to gain some insights into where gender norms are at play. We pulled those data sets together and we began a process of trying to harmonize those data, and we pretty quickly realized that boiling the ocean was not going to happen, and that we needed to bring a much more hypothesis-driven approach to it. But we have assembled all these different data sets that are housed within PHS at this point, and we're now using several of them and approaching them from a much more hypothesis-driven angle. These are the data partnerships, the key data partnerships that we've brought together around several forms of data. We've tried to take the view of let's look at all the different possible forms of data that might enable us to gain insights. So, for example, we're partnering with the Institute of Health Metrics and Evaluation at the University of Washington in looking at global burden of disease data and taking a look at what do disparities by gender in various health conditions look like around the world over time, over space, over age, and what does that pattern look like, and what are the risk factors that underlie those patterns, and what do those risk factors tell us about the forces that are driving disparities in health, not so much the health status itself, but the gender disparity in that health condition. We're looking at various longitudinal data sources in which we can look across the life course and try to look at earlier events that may be influencing changes in health that are related to gender over time. We've identified 2 key data sources, one from South Africa and one from Brazil. In Brazil, they have 3 different cohorts that we're taking a look at and beginning to follow individuals over the course of time. We're doing a similar thing with a British set of birth cohorts that date back to 1946, and each of these provide particular opportunities. And then there's looking at a whole variety of cross-sectional data. One of the main opportunities here is trying to look into the demographic and health survey data over multiple countries stemming back to 1986. And trying to gain insights through looking across countries and time within this large data set. And then we've turned to looking at some particular data sources that are rich in data on adolescence. Adolescence is a key period of time when one really transitions from being primarily shaped by norms and imbibing and understanding norms to being one of really reflecting on, well, how do I want to respond to those norms? And what do they mean for me? And how do I want them to shape me or not? And how do I want to shape them on behalf of myself and other people? And so it's really a key period of time to try to understand what's happening during this transitional period during adolescence. So we're looking at data with the Pop Council and the Girl Center. The Girl Center was just established with funding from the Gates Foundation just about 6 months ago. And they're pulling together data from their various country studies, use a lot of common methodology, a lot of common even questionnaires, so that this data can be pulled together and looked at collectively. And then we're also partnering with Columbia University and CDC and looking at a particular set of studies done in countries trying to understand the origins of violence against children and the impacts of that violence on both boys and girls. I won't go into this in detail, but along the left side here are a number of the health behaviors and outcomes that we're looking at. This has been a process of trying to think about what are the health outcomes that we would want to look at, what are the pathways between norms to those health outcomes, and to what extent will the data sets enable us to answer these questions. So it's really been a process of zeroing in on what are we actually capable of doing that is of interest with these outcomes emerging as the key ones where we have those opportunities. So just very briefly, in looking at global estimates of disease burden, as I mentioned, we're zeroing in on the disparities in health conditions and beginning to work with IHME to zero in on the risk factors for those disparities across space and time and age. In using longitudinal data, we're able to go back even to the pregnancy period in many cases, look at antenatal factors, look at early life factors, and then look at conditions like, for example, in South Africa and Brazil both, but particularly in South Africa, where you're seeing the emergence of obesity as an epidemic among adolescent girls. And on the other hand, you're seeing the emergence of violence among boys as an epidemic. So what is it that's driving those gender disparities in these behaviors and these health outcomes? And then in looking at cross-sectional data, as I mentioned, we started out with DHS with a very broad look at the data and began a process of trying to harmonize that data across countries and across time, realizing that this was a very extensive exercise, and so we began to really zero in on selecting the countries, the particular data set, the variables, and then begin a harmonization around a particular hypothesis and the use of data that would enable us to address that hypothesis. So this is an effort that Valerie's been leading. And then in cross-sectional data, we're able to look at a variety of different health outcomes across the life course. We're really viewing this as from a life course point of view, again, with socialization starting very early in life and impacting us throughout our life course. So this is all a way of saying that we're in the midst of a very challenging effort. Most of these surveys were not designed with this particular question in mind. But it's one that, again, we feel is extremely important if we're going to make major advances, continue to make the kinds of advances that we've been making in reducing maternal and child mortality. I think we're increasingly being held back by these kinds of issues, and this is an attempt to try to get to one more level of understanding so that we can be more specific as we design and introduce interventions so that they're actually taken up and have the intended impact that we're seeking. So thank you.
That was terrific. Thank you so much, Gary. My name is Marcella Alshon. I'm an assistant professor in the CHPP core, the Primary Care and Outcomes Research in the Department of Medicine here at Stanford. I'm trained as a physician and economist, and I will be moderating the panel. And I'd just like to, we've heard a little bit about Gary's background. I thought Amy and Valerie could introduce themselves, and then I'll turn it over to Amy for some discussion of the slides and her experience in the community locally.
Sure. I'm Amy Gerstein. I'm the director of the John W. Gardner Center for Youth and Their Communities in the Graduate School of Education.
I'm Valerie Meozan. I'm an assistant director for data implementation, and I've been working on the Gender Norms Project along with my other PHS colleagues, Ivan and Emma, who are sitting in the back of the room.
Okay, so thank you very much, everyone, for this opportunity. This work is incredibly exciting and important, and great opportunity for me and our colleagues at the Gardner Center to think differently about the kind of work we're doing locally. So just a few words about the Gardner Center. So the John Gardner Center is based in the Graduate School of Education, as I said, and we are a center that is focused on partnerships with the community. We do community-driven research to use data to improve outcomes for youth and address inequality. And we do this in a variety of ways. We have a variety of methods. We use mixed methods, but one of the key ways that we work is with integrated longitudinal data analysis, which is one of the reasons we're sitting in this room. And so we think a lot about how to cross boundaries and look across disciplines to help youth and families think about how to understand the kinds of issues that communities and families are facing, but also how to best understand the kinds of opportunities for solutions. When listening to Gary and thinking about the gender norms work, we work domestically at the Gardner Center. We tend to work locally, as in East Palo Alto, Redwood City, San Francisco, Oakland, but also Fort Worth, Texas. You know, we work across the country and across California. But we share a lot of the same goals. We're action-oriented in our goal, like you are, where our hope is that when we're doing our research, it will result in improvement, and that we're building capacity along the way of the partners that we're working with. And also, we have this multidisciplinary approach. We don't have quite as many research partners as you do in that slide at this moment, but we're hopeful. But when we work, you know, one of the things that is really a challenge is the enormous privacy laws that we are dealing with in education. We know we're all trained in HIPAA so that we can work with health data, but when we work in a community, part of what we're doing is trying to bring folks together that have anything to do with youth. So that might include folks that work in juvenile justice, as well as welfare, parks and rec, the city, and as well as schools and education. So we're trying to link, when we link data, we're linking it at the individual student level. So we're doing it in a very unusual way, and because of that, and because we need to get get these large administrative data sets, it's actually highly relational for us, because we need to get permission from each of these entities, and in order to do that and get all these data use agreements signed, it's actually interpersonal work for us. And so we have, you know, we don't have the same number of data files that Mark and everybody here does, but we have a lot, and it's all been shoe leather that's helped us do it. But I think there's enormous potential to try to work at the scale that Gary has talked about. We also see the links between poverty and health outcomes. We see the links between education opportunities and poverty. All of the things that you talk about health and gender, and we see all those things playing out on a small level and a very local level. When we do this work, we're often calling it the youth sector, because we start with youth as our focus. And when we talk about cultural norms, we often are talking about sort of one institution. And I think it's been very useful for us and for me to think about cultural norms more broadly, and to think about what's the referent group. We tend to think about it at an institution level. One of the indicators that we tend to use whenever we're looking at data and doing analysis is we disaggregate by gender always, but we also disaggregate by all the different ethnic groups and all the different multiple demographic characteristics. And one of the recent studies we did, which is an incredibly important indicator for a number of things, was on chronic absence. Chronic absence in this state, and tends to be nationally, is defined as missing 10% or more of the school year. So that's about 18 days, 20 days. That's a lot of school to miss. And so if you've missed that much school, you're really in trouble. And we've done analyses of chronic absence in a school district where we've looked longitudinally and tried to look at, you know, predictive factors and also consequences. And one of the things that came out in a recent study of chronic absence was that there was a gender effect that only showed up in adolescence, that only showed up in high school. So what was really important there was to dig into it. So first, when it showed up, we said, oh, that's interesting, so let's take a look and see. It turned out there was not only a gender effect, there was also an effect that was that it was not just girls, it was also Latino girls. And this was one particular community, so if anybody walks out of here and says, like, you know, that I said there's a problem with Latino girls in attendance, and it's writ large, you know, I'm just talking about one community. And so we were able to look into this and try to understand a little bit more by adding in some additional methods. So we also do a lot of work that's qualitative. So we were able to dig in a little more into this school district and try to understand what is it that's going on for these Latino girls? What is it that's going on? And then by also looking more carefully at which days of the week did they attend and which days of the week did they not attend. And we were able to construct a story to understand what was actually going on. Which meant they were attending on Monday, not attending on Tuesday, not attending on Wednesday, showed back up on Thursday, didn't attend on Friday. So we were able to figure out more, and also able to see much more about what kinds of factors were leading to that, and begin to design some interventions to help. So that's an example of how gender has played out for us locally, and how we've been able to understand how important context is and how important it is for us to use mixed methods. One more example of our local work that I think is relevant is one strategy that a number of communities use locally but also nationally is something called community schools, which is where schools or districts form a full service partnership. There may be school-based health centers at a school, and this could be K through 12, or but there are all kinds of partnerships based at a school to help serve youth and families in all of their needs. And this is particularly important from a health perspective. So they often have dentists as well as doctors, counselors, and so on to help very vulnerable populations of youth. We've been trying to study those kinds of schools to help understand how do we tell if this is working and what would be the kinds of data that would best tell us that, because it wouldn't just show up on test scores. And we have had challenges with, with the school-based health centers are holding tight, as you can imagine, to their data as they should. And so these are the kinds of challenges that we face, but we with the data. But we also understand that when the community school model is in place, we see improvements in a lot of the educational outcomes. But we could use support in trying to understand more generally how to support some of these communities and thinking it through. And I guess just one last point that I would make is that as we do work locally, one of the biggest issues that's come up, especially in the last few years, has been in a very high incidence of trauma has been showing up in all the communities in which we work with. And this is for both children, but also for their families. And we see this showing up, and the schools are overwhelmed by it. And it's related to a certain degree. It's tied to increased immigration. It's tied to unaccompanied minors that have immigrated here from Central America. It's tied to a whole host of things that are related to poverty, and from food insecurity to all the things that are related to poverty. And this is an example of an area of research that would be that is ripe for collaboration. And the schools are, as I said, the teachers are first responders in many ways and are struggling, and we are working to both help understand it and help provide appropriate advice around appropriate interventions. I think I'll pause there.
That's terrific, and very helpful, I think, to look at the intersection between global and local and the overlap between both the process for obtaining the data as well as sort of a mixed methods approach to analyzing it, and actually just seeing how there is no lack of problems here at home as well as abroad. But I wanted to turn to Valerie at this point because Amy mentioned relation building and shoe leather. Can you tell us about the process for collecting the data that you've gone through so far? How did you search for the data sets? And what did you do if one source didn't have all of the data that you needed?
Thank you. So I will start by saying that no source had all the data that we needed. I think that was more the common scenario. But we definitely had, we approached the problem via different angles. A really important one is just word of mouth, just listening to what people have done with the data and collaborators that we're working with, how have they approached the question, what are their advice, what are the studies they know or other collaborators in other universities they're aware of. That was definitely a huge contribution in helping put that list together of potential data sets. And then once they allowed to, once they gave it that breadth of data sets to dig into, then came a lot of work in both acquiring the data. These were mostly publicly available surveys, so we were really lucky to be able to gather a lot of publicly available rich data. But in terms of then the devil was in the details, in really being able to understand how to operationalize gender norms in the data. How do we capture this concept that's fairly intuitive to grasp, but really be able to get down to the variables that were going to make a difference? And a lot of it was also trying to understand sort of what is the normative context we're interested in describing. And so some indicators will help inform that context for specific health outcomes that we're interested in studying. And then a lot of what we've done as well is look both at papers that have started tackling these issues and what indicators and data sets they have used, along with other qualitative research that have talked about these issues in more lay terms, but that we can then extract in indicators in the data. So then it's a lot of collaboration, Googling, and then getting into the data dictionaries to see if the indicators are the ones that are going to be helpful.
That's fascinating because I kind of ex ante thought that maybe there was some PubMed or some sort of very fancy, but it sounds like it's somewhat relational as well at the end of the day, at least to first figure out what's out there. I was interested in your harmonization process, if you could speak a little to that.
So as Gary mentioned early on, we were really interested in bringing a lot of publicly available data sources together, and when questions were similar across different survey sources but not exactly the same, how could we bring them together to create one large data set that could sort of leverage all these different data sources together but make it sort of easier to use for the researchers. And we developed a technique or an approach in terms of, you know, a lot of code was written, especially by my colleagues here, on how to grab different indicators from different survey sources, compare them, and then find a common definition. So that's really the standard part, like finding a common definition that fits all the survey sources. When it comes to gender norms, actually, the additional challenge that we're facing, I think, is really around missing data or incomplete data. So creating a harmonized data set in the context of gender norms is actually pretty challenging because there's no complementary data consistently. So a quick example is, for instance, there's no consistent data for both men and women. So something may get asked to women but not to men. So there's actually no complementary variable to harmonize. Some questions are biased in a way that makes it hard to just get the right definition. So there's a lot of quality control to do. I think the harmonization approach is definitely something that I think is still valuable for other more general health indicators. When we talk about gender norms, the capturing, like making sure that the question is asked in a way where we're capturing what we think is a norm is the challenge.
That brings up another question that I had, which is, how do we ask, so I think it would be helpful to just give an example of what you might be thinking of when you think of a gender norm, just concretely, but then it struck me that questions, and this probably comes up in your work too, Amy, and when you were carrying out, you know, introducing technologies, Gary, in Malawi or in Bangladesh, how do you ask sensitive questions and feel like you're getting a truthful response? So sort of two questions there. One is, what have you found so far as sort of a universal gender norm, and maybe even a sort of meta question on how do we ask sensitive questions, and in your data analysis, when you see those missings, do you worry?
Mm-hmm. Do you want me to?
Maybe I'll start out just saying that I think we've come around to the view that gender norm data doesn't really exist within survey data. it has to be inferred. I think the only way that you can get gender norm data is through some pretty careful questioning that is much more amenable to a qualitative kind of approach, and I really appreciate the comment that Amy made about the use of mixed qualitative and quantitative methods, and I think the way we're viewing this is that we're aiming to generate hypotheses about where norms are existing. You know, we're looking at geospatial data, as you might have presumed, you know, in the way we were talking about the reference group and trying to understand those who are influencing a particular person's attitude or their behavior. For example, I think network data can potentially be quite interesting, and that was one of our attractions to the Gardner Center data that Pop Council has, for example, is that they do have some data on social networks, and trying to trace influence through those networks can be quite powerful. Some of that could possibly even be done with social media type data, for example. But I guess the short answer to your question is that we're still learning about how to construct the data and interrogate it in a way that we believe is leading us to identify where a norm is acting. I mean, I think that we have some important leads, and we're taking several different approaches at it. And one of the great things about having this grant from the Gates Foundation is that they've given us that freedom to really explore and to fail and to figure out what doesn't work and to reformulate our approach and to keep trying. And I don't want to give away too many secrets at this point, but I think that we are making some progress and beginning to understand the data much better. But I think we have come around to the view that for one, neither sex disaggregated data nor gender data actually exist. It's a combination of both of them, I think, in all cases, except for maybe identification of sex at birth for most people. Beyond that, the gender elements enter into you know, a socialization process that immediately takes it away from being purely sex disaggregated data. And so that's another thing that we've had some discussions with IHME, for example, about how do we begin to try to disaggregate sex and gender influences. I think that's a whole nother frontier. And then how do we ask better questions to get at that data?
Thank you.
So I appreciate those comments because we tend to let me say, a lot of our work, as I mentioned earlier, is about capacity building, and we take very seriously the role of every partner we work with in the community. We are hoping that they will become more skilled at looking at data, and one of the outcomes is that as people in the field get better at looking at data, they realize that it just raises more questions for them, right? And so that's good news and bad news. And I think that as we learn to look at the data better, we start to realize we have more questions. And I think that's a perfect example that you're describing, Gary. And so when going back to that example about chronic absence, when we noted that there was a gender differential and big variance, we also started using some survey data and some interview data. And when we noted that there was a challenge with Latino girls' attendance, we created some surveys, and we also learned that Latino boys had some other problems that hadn't been surfaced. And so that was, you know, from our perspective, we were like, this is great news. We're learning more, and this is great. And it was really helping surface issues that needed to be addressed. From the school district's perspective, you know, they not so much. I mean, they thought, great, you just found another problem for us. And we thought, great, this is another opportunity. You know, you can work on some issues that were really important that might be getting at some of the other issues that were leading to some of the chronic absence. So I think for us it was about surveys as an opportunity to start to ask some of those sensitive questions, but we also take very seriously the how hard it is to do that, and depending on the sensitivity, we conduct interviews or focus groups, and we're very careful about that. And we, when doing that work with families, we're very careful to do that in their primary language, and in small groups. And I mean, it's things that I think everyone here would do.
And because we're talking about kind of looking at data, trying to figure out maybe patterns of norms, patterns of maybe demand bias and how questions are answered, have you thought about machine learning techniques or other algorithms that might be useful to start analyzing the data? Or
yeah. So as Gary mentioned, a lot of the work is exploratory in trying to understand what domains go together. And so I think in that way, we are looking at clustering techniques to eventually inform what, health behaviors may be attributed to certain outcomes or some attitudinal factors. And so I think it's mostly to do some of those exploratory initiatives.
We're partnering with a faculty member in the Graduate School of Education to begin our first study using machine learning. I don't know anything about it, so I'm not going to say.
Stay tuned.
Other than saying that that's about to happen.
Well, that sounds exciting. Okay, well, I thought I'd open it up to some questions or comments from the,
My question is for Gary. I'm very interested in this connection between gender norms and health outcomes, but I'm particularly interested in why there should be a connection. I'm interested in what mechanisms might be driving the linkage between these two endpoints, and I was just wondering whether you have some theories about what the connecting mechanisms might be.
Yes, thank you. As part of this work, we've developed a conceptual framework to help guide our thinking about these concepts, but also about the data construction that we would use to try to test some of these hypotheses. I would say one of the key elements that comes into the conceptual framework that I think drives a lot of the norms is fundamentally comes down to power. Comes down to power relations and a hegemonic construction of society that necessarily ends up resulting in gender norms because of that construction. And so then we're looking at ways in which that construction is reinforced at various levels of society, within the family, again within media. I gave you we saw a great example there of a gender norm construction that's embedded into advertising, even though we're relatively a highly equitable society, but still, we have these underlying drivers of creating those norms, and I think a lot of it comes down to fundamentally perpetuating a system that has come out of a power differential that's based on hegemonic masculinity. I think that's a lot of it. And then out of that, we see various pathways at the individual level, at the societal level, where you have various kinds of forces within each of those levels that are either maintaining or that are butting against those norms, and then how that is linked to health is what we're trying to trace. So, for example, as the example, one of the examples that I showed, you may have differences in care seeking that kind of you trace back to the value of the girl child relative to the boy, and the opportunity cost involved in seeking that care for that child. And it kind of comes back to fundamentally a value that's placed on that boy or that girl. So that would be one example. I think a really important issue too is intersectionalities that you mentioned, Amy. This is something that appears very strongly in our conceptual framework, because it's not really just about gender. It's not all about gender, but it's a very important factor, but it intersects with many other factors. And it's often at those intersections where some of the greatest disparities exist. You know, if you're a girl Latino, for example, or you're a girl from the lowest caste in India who's also very poor, and particularly if you're Muslim, you have many different factors that begin to stack up that lead to discrimination against you for a whole variety of reasons. So we're trying to take those factors, those multiple intersectional factors, into account as we do our analysis as well.
Yeah, I had a question for Gary too. Gary, it looks like you had a lot of interesting data sets available to analyze. I was wondering if there'd be an opportunity or it'd be of interest to, if it's available, to look at early puberty as a health outcome, because I'm thinking that gender norms and probably sexual violence may influence that, and then early puberty may be a risk factor for obesity, and I know it's an established risk factor for breast cancer, so that might be something interesting if that data is available.
Yes, it would be, and that's what's made us seek in particular data that has early adolescence within it. If you look at the DHS, the multiple indicator cluster surveys, they measure up until age 5, and then they pick up again at age 15, and they miss that really critical period. There are a few data sets. The Gardner Center has some. The Violence Against Children survey, again, there's a Young Lives 2 surveys that have been done in 4 countries that have some early adolescent data. And then there's another new data set coming out of Johns Hopkins called the Early Adolescent Health Survey study. So far they've published some of their qualitative findings, but they're assembling a multi-country data set of early adolescents that may provide us some of those opportunities. But so far it's been pretty limited in looking at that particular time period, but it's a key one.
Well, I think we're at time, so thank you very much to our panel, and thank you to, oh, I'm so sorry, one more.
Oh, go ahead, Emil, go ahead.
I'll try to be quick. I guess for Gary and Valerie, I'm sure this is something you're thinking about actively, but in terms of the harmonization, how are you grappling with both the cohort effects and then the context effects being just so wildly different? And by context, I mean country level or within country, or, you know.
So at this point, we're really going in a stepwise fashion. So we're not trying to harmonize everything. We're just picking selected health outcomes and saying, okay, for those, this is what we have in different sets of data for such age groups. And then we build from there. Basically, the approach is we start with a limited set of indicators, and then we build from that. And I would say the indicators that we're really able to harmonize at the moment are sort of more objective indicators around health outcomes. I think some of the attitudinal questions and things like that are a bit more difficult to harmonize. Luckily, though, I will say our biggest sources of data is DHS, and they have recoded and are harmonized a really large majority of indicators already.
Thanks.
Anyway, I want to thank the panel and Gary. It was fantastic. Oh, you wanted to give another comment?
I just wanted to add just really quickly. I think your point about context is really important because these issues are very, very contextual. And so what we've come down to is trying to find the cleanest data that would enable us to trace a pathway and to develop some methodology that would enable us to draw some links between what we think are reflecting norms and health outcomes. And so we're getting away from kind of really the big picture and trying to come down to very specific instances where we can gain insights and learn how to do this, and then begin to think about how we can expand that to other kinds of settings.
Great. Anyway, thank you all very much. It was really terrific. So I'm the last thing standing between you and the wine bar, which is out there. But we do have we do have one more clearly serious piece of business to do. PHS would not be PHS without Gita, as you know, and she and the rest of our fabulous staff. We'll go around. Linda, who many of you know, Rita Loneheart, fantastic. Where is everybody? Can't even see everyone. But anyway, thank you all for the task, but for the fabulous effort supporting the conference today. But we do have one more little task, which is that, of course, we have a door prize. We wouldn't be PHS if we didn't have some swag for you. In fact, we have 2 door prizes. And we did a little raffle earlier in the day, but because of the funny way the day went, the winners of the raffle aren't here. So we decided we're going to have a quiz. So before you get your glass of wine, we have a quiz. The winners get, I'll show you the, this is the prize. There's 2 of them. So we have a morning quiz and an afternoon quiz. So here's the morning quiz. So Klalit is one of the oldest and maybe the oldest single healthcare system in the world, which you heard about. And Alcoa is, in fact, the oldest aluminum manufacturer in the world. Didn't give you, well, some of you may have caught dates. You probably didn't. Which is older? Someone say Alcoa. Amy's the winner. So just for the record, Alcoa was started in Alcoa, Tennessee in 1899. Klalit began in 1911. All right, so here's the afternoon quiz. So which is older, the first DHS survey of the ones we've been using in the 90 countries where it's been used, or the oldest baby in the LSPAC cohort? DHS 1984, oldest baby in LSPAC 1991. You win. Now everyone can you want to deliver the prize here? No, I did. I think we can now all adjourn to have wine and to do whatever socializing hasn't been done in the course of the day. Again, I want to thank the panel and my phenomenal staff for a well done, put together day. Thank you all.